Hello, everyone. Welcome to the TTS-TID webinar on global adventures after the pandemic, ensuring safe travels for transplant patients. My name is Wanessa Clemente. I'm a TID doctor and a professor at the Federal University of Minas Gerais, Brazil. And it's my pleasure to chair today's webinar alongside Dr. Peter Chiodini, who is a consultant parasitologist at University College London Hospitals, as well as Dr. Cameron Wolfe, also a TID doctor, professor of medicine at the Duke University, and a member of the Executive Council of the TID section. We are all thrilled to have you join us for this webinar. Today, we will explore the critical challenges affecting the health and the safety of SOT recipients related to travel. As travel is becoming more prevalent in a post-pandemic era, new global factors, including global warming, have emerged to change the risk scenario. With travel restrictions now lifted, both patients and the potential donors are more mobile than ever. At the same time, climate change is remodeling the spread of diseases, making risk management more complex. To reduce risks, we need to focus on effective prevention, early recognition of disease, and timely treatment. Medical guidance before and after travel plays a key role in keeping patients safe. Discussion is therefore more important than ever, and we are excited to dive into these topics with you today.
Hey, thanks very much, Vanessa. In this webinar, we're going to listen to 3 presentations by our distinguished speakers, followed by a live panel discussion. The webinar includes intentionally experts from a diverse geographic background, including endemic and non-endemic countries. So thank you for taking part in the webinar series hosted by the Transplantation Society in collaboration with the Transplant Infectious Disease section. It's endorsed by a number of groups today. It's endorsed by the International Society of Organ Donation Professionals, ISOTP, and the ESCMID study groups for infection and immunocompromised hosts and infections in travelers and migrants. So our first presentation will discuss global burden of trends in tropical and endemic diseases, a risk assessment. That's going to be given by Dr. Michele Morris. Second presentation will discuss how to protect your patient, so vaccination, prophylaxis, and preventative health. That'll be presented by Dr. Oriol Manuel. And then last but not least, Siriorn Watcharananan will discuss the returning traveler and how to handle that situation. So each present for about 15 to 20 minutes on these important topics in transplant, infectious disease, and travel. And after our speakers will present, then we'll have an open floor for 10 to 15 minutes each. In total for a discussion. So we'd encourage everyone who's online to ask questions and make any comments throughout the webinar. You can do that through the Q&A window. We'll try and answer as many of these as we can, either during the live Q&A periods or as the discussions go along. So we'd really like this webinar to be as interactive as possible. I think that helps us all learn. Please don't hesitate to post your questions or comments. Thanks. I've got a real pleasure in introducing Dr. Morris. She's a professor of clinical medicine, the director of the Immunocompromised Host Service Division of Infectious Diseases, and a medical director of the Infection Control and Antimicrobial Stewardship Program at the University of Miami Hospital, and I've been someone I've really seen personally as a great mentor over many years. So, Dr. Morris, we welcome the start of your presentation.
I'm honored today to be able to present regarding global burden and trends of tropical and endemic diseases, a risk assessment. We all know that the planet is warming, and unfortunately, 2024 was the world's warmest year since records began in 1850. In fact, the Earth has surpassed 1.5 degrees centigrade in the hottest year on record. 58% of known human infectious diseases have been aggravated by climate change. This includes many travel and endemic diseases, including vector-borne diseases, waterborne, and airborne diseases. And tropical and endemic diseases are clearly increasing. Climate change has expanded the geographic range of vectors, including mosquitoes and ticks. It's increased the vector reproduction rate and enhanced pathogen transmission. Human migration, in part due to climate change, has also expanded the risk, as has deforestation and urbanization. Vector-borne diseases in the United States actually doubled between 2004 and 2016, both due to an increasing number of pathogens, some of them new, and an increased geographic range of the vectors. We've also seen an increase in zoonoses. And in the face of multiple climate-related disasters, there have been more foodborne, waterborne, and airborne infections seen. In a 2024 review by Dr. Phillips in the Journal of the American Medical Association, a specific list of vector-borne diseases was included. Some examples are here, and the geographic range as well as the presentation of these infections has occurred. Zoonotic diseases, including some novel human pathogens, have emerged, and there have been new fungi that have appeared, as well as increasing range for endemic mycoses. Waterborne diseases have thrived, both moving northward and expanding after storms and flooding and other climate disasters. Our transplant risk groups have been impacted by this increase in tropical endemic diseases. Transplant candidates may be exposed. Living donors may be exposed both before they consent to donation and in the days leading up to organ procurement. Deceased donors may be infected, and this infection may not be apparent to those who consent for the donation. Transplant recipients may be exposed through travel or occupational exposure. This is a outline from a document by the U.S. Organ Procurement and Transplantation Network geared toward recognizing infection risk factors in transplant donors, but also applicable to our candidates and recipients. This includes geographic risks, country of birth, the site of organ procurement with deceased donors, and prolonged travel. Occupational risks, including healthcare, animal care, outdoor work, and any international stays through either the U.S. Peace Corps, military service, international work, and even medical missions. Seasonal risks are apparent for our vector-borne diseases, and certainly the seasons are expanding. Hobbies such as hunting, camping, gardening, and adventure sports can lead to exposure, as can unusual pets, and a family or personal history of seasonal or geographic infections such as TB, malaria, or Chagas disease may increase suspicion for disease in our transplant patients. This chart looks at specific pathogens and climate change risk. The Plasmodium vector of malaria has thrived in the face of the global warming and has caused reemergence of malaria in temperate regions which haven't seen infections in over a century. Flaviviruses such as dengue and Zika have expanded, such that dengue incidence has increased 30-fold in the past 50 years. And urbanization has led to new sites for the mosquitoes, both during flooding and when human water storage has occurred in droughts. West Nile virus, which can be transmitted by a whole host of mosquitoes, has increased in the face of climate change, as in a 2010 outbreak in Europe due to an extreme heat wave. And both the mosquito vectors and bird migration patterns have expanded. Lyme disease has also increased as the tick vector as well as small mammal populations have increased in range, such that cases have emerged in Canada and the Arctic. Strongyloides, a free-living larvae that can survive better in a warmer environment with improved reproduction. There's been increased geographic spread to non-endemic areas also in cases of flooding where the water sources can be contaminated. And finally, Toxoplasma gondii. There's been an increased density of the small mammal hosts, as well as improved oocyte survival and infectivity, leading to new geographic areas of involvement. On to dengue, a flavivirus that is transmitted through Aedes mosquito bites and is associated with a viremia that can spread the infection also through infected blood, organs, and tissues. It's endemic throughout the tropics and subtropics, and the area of risk has increased significantly in the face of urbanization, human migration, and warming. It's estimated that there are over 50 million asymptomatic cases a year, but 40 to 80% of cases are actually asymptomatic. Though less than 5% of cases in general are severe or life-threatening, a recent review of over 380 solid organ transplant recipients found that 13% of these cases, 50 cases, had severe dengue, and 14 of these specific cases were donor-derived. So that our transplant patients are at risk in endemic areas and with travel post-transplant. And the travel range is large, with this risk map showing much of the world, and even isolated outbreaks in Miami, Florida, where I practice, and also in Hawaii and Texas in the US, resulting in local transmission in new areas. Malaria is an infection that is worldwide, with almost half of the world's population exposed daily. We know that doubling of atmospheric carbon dioxide will increase transmission capacity of the mosquitoes 100-fold in temperate areas. But actually, climate change and urbanization could favor dengue transmission over malaria in sub-Saharan Africa, which is really the epicenter of transmission. The Anopheles gambiae mosquitoes transmit infection best at about 25 degrees centigrade, whereas the Aedes aegypti mosquitoes transmit best at about 29 degrees centigrade. But this is not a sharp cutoff. There's a linear increase, such that we're seeing a shift to more dengue transmission. Unfortunately, there's less arbovirus surveillance in high malaria locations, leading to some unrecognized infections, and control strategies that are well established, like bed nets and indoor spraying, aren't effective for daytime biting urban Aedes mosquitoes. So we've already seen a shift from malaria to dengue and chikungunya in the Caribbean and South America, and it's likely that that's going to occur in Africa in the future. Here we have a map of malaria risk from 2024, again with the African epicenter where things are starting to shift. On to chikungunya, an emerging arbovirus transmitted by Aedes mosquitoes. The range, as we noted, has been changing. It's characterized by high fever, rash, and headache with polyarthralgia that can progress to severe and chronic arthritis in up to 50%. There are rare, severe severe manifestations seen with chikungunya, even potentially resulting in death. A 2018 review of 10 cases, as well as 31 cases from the literature in solid organ transplant recipients, found no severe complications, rejection, death, or chronic arthritis. And it was postulated that immunosuppression may actually decrease the long-term inflammatory arthritis in transplant recipients. This is a recent map of chikungunya transmission over the past 5 years, but this map is changing constantly. Chagas disease is an infection with Trypanosoma cruzi transmitted by bites of bugs. It's endemic in Latin America with 6 to 7 million infected, but is also seen with a large number of cases in Europe and the United States. And it can be transmitted by blood transfusion and organ transplant. The blood supply is screened well in the US, Brazil, and Argentina, but many endemic countries don't have routine blood screening. And there's therefore a risk in transplant from infected donors, so that we should consider screening high-risk donors. There's a risk for reactivation in infected recipients who need to be identified with screening pre-transplant and monitoring post-transplant. And there's certainly a risk in new infection in travelers, but it would require more prolonged stays, likely more than 3 months, in order to transmit in more rural areas. A recent seroprevalence study in US transplant candidates found 4.8% of over 1,500 transplant candidates tested positive. There's been an increase in tick-borne diseases, in part due to climate change, but also reforestation, increased deer population, and an expanded wildland-urban interface. And in fact, in the last 40 years, there's been a lot of new tick-borne pathogens identified that can infect our transplant recipients. Moving on to emerging pathogens that we've seen in the face of climate change, Candida auris developed or was identified first in Japan in 2009 and then emerged simultaneously on 3 continents between 2012 and 2015. You can see this emergence pattern here. This emergence has been attributed to climate change because Candida auris is far more thermotolerant than other yeasts and also more tolerant of saline environments. It is very transmissible in healthcare settings because of prolonged colonization in multiple sites on patients, including the axillae and groin, and colonization of surfaces throughout the medical center. Risk factors include abdominal surgery, antibiotics, intensive care unit care, catheters, and diabetes, all risk factors that we see in transplant candidates and recipients, and transmission in healthcare centers occurs. The challenge with Candida auris is a significant amount of antifungal resistance, particularly to fluconazole, but extending to about 40% of isolates to amphotericin products, and in a small percentage of isolates also to echinocandins, which are currently the drug of choice. There's a high associated mortality with these infections, which we've seen in our transplant units. Oropouchi virus is a new and emerging virus transmitted via biting midges and mosquitoes. It is actually found, the virus can be found in semen, and there's a question whether it can be spread sexually. It presents with fevers, chills, myalgias, arthralgias, nausea, vomiting, and photophobia. But other manifestations, including GI manifestations, conjunctivitis, and meningitis, are seen. And less than 5% develop hemorrhagic symptoms that can involve the mucous membranes and the GI tract. Symptoms develop 3 to 10 days after an insect bite and can last 3 to 6 days. But unfortunately, there's no antiviral therapy identified, and supportive care with the avoidance of aspirin and nonsteroidal anti-inflammatories is recommended. Finally, highly pathogenic H5N1 avian influenza, or bird flu, has emerged significantly throughout the world. This map shows areas where the infection has extended beyond the avian hosts into mammalian populations. The current outbreak in the US usually infects humans after close, unprotected exposure to infected poultry or dairy cattle or their environments. But wild birds have also transmitted infection throughout the world, far outside the map here of mammalian infection. Birds shed the virus in saliva, mucus, and feces, and can infect mucous membranes and the airways of exposed people. Fortunately, milk pasteurization and good cooking of eggs, poultry, and beef kills the virus. and there have to date been no evidence of sustained human-to-human transmission, but the risk remains. Symptoms include upper respiratory congestion, conjunctivitis, but progression can occur to pneumonia and multi-organ failure. In a 2024 New England Journal of Medicine article, conjunctivitis was the most common symptom seen in 93% of patients. And in fact, the best place to identify the virus was in conjunctival swabs. Combination antiviral therapy with oseltamivir and baloxavir may be preferred in hospitalized and immunocompromised patients to decrease antiviral resistance from emerging. So we've talked about a lot of tropical and endemic diseases, but unfortunately I couldn't cover them all. There have been bacterial infections that have expanded in the face of climate change, particularly non-tuberculous mycobacteria and multi-drug resistant organisms. I mentioned that the endemic mycoses have expanded. Candida auris has been a problem, and multiple viral and parasitic infections can be attributed to the changes in our planet. So what are we to do? How can we respond to the changing infectious disease landscape? Well, first and foremost, of course, excellent history and physical exam skills are necessary to tease out subtle exposure history and exam findings such as rashes or conjunctivitis that can raise a clinical suspicion. Practitioners need to follow the news and be aware of extreme weather events and natural disasters that may impact infection risk. We need to monitor government and organization websites for outbreak alerts, and then anticipate the risk at our centers by planning for and being ready to respond to worst-case scenario events that may result in patient exposure. We can mitigate the risk with the use of insect repellent and protective clothing, as well as travel and lifestyle planning. But we also need to expand the diagnostic capacity by arranging for access to laboratory testing that may not be a routine in our medical centers. And finally, for the infectious disease experts in the audience, it's crucial that we educate our colleagues so that we prepare local primary care docs, emergency room staff, hospitalists, and specialty colleagues to recognize novel pathogens and unusual presentations in the era of climate change. The global transplant community must be ready to meet this challenge. It is our duty to protect our patients and our planet. I thank you for your attention.
Many thanks, Michele. We should absolutely be thanking you. I hope you can hear me after I expunge the gremlin from my microphone, but that really was a lovely presentation. Now, no one's put anything in the chat, but I have one verbal question to put to you now because we're within time. And I encourage the audience, and there's a good number on, to put their questions in the chat because this is your meeting. We've put this on for you, the participants. So my question to you, Michele, is what sort of formal training is given to transplant personnel? It will vary by jurisdiction, obviously, but for example, in the UK, we say, oh no, not another strongyloides in a renal transplant patient. And we've been telling you this since the 1990s. And it's because they do their transplant training, we do our ID training, but the crossover can be quite weak. So what happens on your patch in terms of training your own transplant staff?
Well, that's a great question. Thank you, Peter. And we do constant education in our conferences to every level of the transplant team. We meet with the coordinators, we meet with the nurse practitioners, the pharmacists, the surgeons. We present cases in morbidity and mortality conferences. And we have designed protocols for screening and created laboratory panels. We do uniform screening in Miami for Chagas disease. We do uniform prophylaxis of all of our transplant recipients for strongyloides. So depending on your location, it's really crucial to be involved in making sure your team is ready.
Perfect, thank you. Now, so I'm going to proceed on now to introduce our next speaker, Dr. Oriol Manuel. Now, Oriol works in Lausanne, Switzerland, and he's at the University Hospital there. And he's that rare commodity, because we don't have them where I work, is transplant infectious diseases specialist. He also does clinical research. So given his background, I'm very excited to hear what you've got to say, Oriol. So please take it away.
So in the next 15 minutes, I will talk about how to protect your patient and which are the counseling and the protective measures that you can do with your transplant recipient before he's traveling abroad. So this is the outline of my presentation. So because only in 15 minutes, I will only give you some concepts about the topic. I will not be into detail, but maybe we can discuss in the chat after that. But we'll start with some concepts about the risk of infection in the transplant traveler, which is different to transplant recipients with a normal traveler, and why they have a higher risk for infectious complications. And then I will move my presentation discussing a little bit about prophylaxis, mostly malaria and travelers' diarrhea. And then I will also talk about vaccination in the transplant traveler. So the first concept that I would like to convey is that actually solid organ transplant recipients are, of course, immunosuppressed patients, but actually one of the most important risks of infection of these people is that actually they receive a very strong surgery. And actually you can see here in this slide, this is data from the Swiss transplant cohort study that we followed all transplant recipients in Switzerland. And we prospectively followed the episodes of infection that they develop after transplantation. You can see here that actually is during the first phase in the first weeks and months post-transplant where the risk of infection is much, much higher and then dramatically goes down. And you can see here after the first year of transplantation, the risk of infection is much lower. All of this is, as I said, is related mostly with surgery, not that for immunosuppression, but we can still see some cases of opportunistic infection below, but after 12 months, but it's much uncommon. So only looking at this slide, you can see that probably it's not a good idea to advise your transplant recipients to travel abroad in a tropical area before the first year of transplantation. And it's better to wait a little bit after the second year. Of course, the individual cases can be discussed, but I think that at least you can wait until the second year post-transplantation. The other concept is because actually transplant so the quality of life increases, they live longer. Actually, transplant recipients like to travel like any other person. And there has been some surveys looking at which is the behaviors and which is the risk of infection in transplant travelers. This is a nice survey that was done in the Leo Visser group in Leiden in the Netherlands. And you see that actually they do a survey about 300 kidney transplant recipients that were following the patient clinic in the transplant center. And then about 1/3 of them actually traveled outside Western Europe or North America, which is a high number. Actually, in the Netherlands, most of these patients seek pre-travel advice, which is, I think, in other countries has shown that it's much more difficult. So about only 1/4 of the patients did not seek for travel advice. And when they seek with travel advice, mostly with the transplant doctors who gave it, not specifically in a travel clinic. Which I think is important of this survey is that actually a significant number of patients were ill during travel, mostly had mild disease, mostly diarrhea, but 4 patients of all the 100 that they travel, actually they were admitted after the travel because of an infection. And mostly was, I think, 2 cases of gastroenteritis and 2 cases of cellulitis, mostly bacterial infections. Another concept that I would like to show you is that transplant recipients are at much higher risk for other complications, so not directly related with infection, but indirectly related, because actually these patients, when they are much more susceptible for diarrhea when they have diarrhea, either for infection or for a secondary adverse event of a drug. They have an increase in tacrolimus levels, which is the most common immunosuppressive drug that they use. And also because of the hydration, they have a very high risk for kidney failure, which in turn will increase the levels of some other immunosuppressive drug like mycophenolate, which at the time will increase the risk for diarrhea. So it's like a catch-22 here. And that makes it that actually in patients that may have very mild gastroenteritis may actually end up with a higher risk for kidney failure and kidney complications. So I will move this with prophylaxis. Of course, when we talk about prophylaxis, we talk about prophylaxis against malaria. I think Michele has already shown you this map about the risk of malaria. Only to say that I think in all European languages, malaria is malaria, except in French, which is here in paludism. I apologize that the slide is in French. But actually, I think the bottom line here, the message is that the counseling that you're giving for your transplant recipients is much similar than for the general population. So we have very few data about which is the clinical manifestations of malaria in transplant recipients. Mostly it's for publications are of donor-derived infection, and probably they have, as I said, higher risk for kidney complications. But actually, we treat these patients at the same way that we do it for the general population. So I think that you need to be based in this map to recommend whether you give prophylaxis or in standby emergency treatment, depending on the risk of the zone. The thing that you need to consider in transplant recipients is that they are taking immunosuppressive drugs, mostly calcineurin inhibitors. We may have some kind of drug-drug interaction, some kind of toxicity. So I try to summarize a little bit here, which is the options that you have for giving malaria prophylaxis in solid organ transplant recipients. First, I think the most used drug is the tovaconproguanil, which is the advantages is that you give it for a shorter duration, especially for shorter travels, and you don't need adaptation for kidney function. However, it's not recommended if your clinical creatinine clearance is below 30. It's as again here the comment that I give you is that probably is the drug that is preferred, but you need to take into consideration that if the kidney function is low, you probably need to use another drug. And there is some small drug-drug interaction, but probably not significant. The second drug is doxycycline, which actually has the advantage that it can prevent oral bacterial infection like rickettsia, like some kind of diarrhea. So that it's very useful and is a very broad spectrum antibiotic protecting for a lot of other diseases, which is probably beneficial in our population of transplant recipients. Had the problem of photosensitivity that was well known with the use of doxycycline, and you need a little bit longer duration because you need to prolong for 1 month after returning the traveler. It's probably the drug of choice if your creatinine clearance it's below 30 and have maybe a more adventurous travel that you have potential other exposures. And again, they may have some mild drug-drug interactions, but are not clinically significant. The last drug is mefloquine that has the advantage of giving it only once weekly, but with the potential neuropsychiatric issues, and also in combination with tacrolimus may prolong QT. So it may be a very more difficult to use in this. And I think that now it's considered as an alternative drug. So probably another advice I can give you is that usually we start the drug a couple of days or a few days before traveling. Maybe it's not bad that in this patient you may start a few days before, and then if you have the possibility, maybe check that kidney function, that everything is okay, that the tolerability is good before traveling. The other issues about prophylaxis or treatment is traveler diarrhea. I show you here results of a meta-analysis. I think all know that most of the causes of traveler diarrhea is bacteria. Mostly it's E. coli, Enterotoxigenic or others, but with a number of Campylobacter, Salmonella, and Shigella that's also important. So again, I show you before that actually diarrhea in solid organ transplant recipients may be more harmful than in the general population. Here is again data from the Swiss transplant cohort study, we saw that actually Campylobacter in Switzerland is the most common pathogen that causes gastroenteritis, with up to 5% of our transplant population. What I wanted to show here is that actually the risk for invasive infection in this patient is much higher than in the general population. You can see that up to almost 8% of patients had invasive infection with bacteremia. And then you can see that two factors that were associated with an increase of invasive infection was being infected with Salmonella. Would you say 45% of the cases were Salmonella, which is much higher with other pathogens, and then also acute rejection was associated with an increasing risk of invasive infection. So I said before that probably during the first year it's better not to travel, but in case you have late rejection and you have been treated for rejection, maybe you should advise your patient that maybe it's not a good time for traveling, because if they have some kind of gastroenteritis, may have some important consequences. And then what we can do to prevent this, so there is a trade-off. So I would say prophylaxis, universal prophylaxis in this patient is usually not recommended, because the risk of adverse events, the risk of drug resistance, also Clostridium. So I think the most specialists or most clinicians do not recommend antibiotic prophylaxis for traveler's diarrhea, unless there's a patient with a very specific situation when you want to with a very high risk of infection but needs to travel. That could be a possibility, but otherwise not routinely done. And what, however, is recommended, this is the guidelines of the American Society of Transplantation by Camille Cotton, that actually usually you can have a standby emergency treatment, that in case of you have moderate diarrhea, so more than 3 stools in per day with fever, blood, then you can take an antibiotic. Here it's recommended a quinolone or a macrolide. I would say that probably macrolide is a better idea, because the risk of resistance to Campylobacter and Salmonella and other and E. coli of ciprofloxacin in some areas is very high, and probably azithromycin it's a better choice for doing that. And then finally, we'll finish with vaccination. So this is a very general picture of what happened in solid organ transplant recipients. So I would say the majority of patients will receive 3 drugs. There is calcineurin inhibitor, mostly tacrolimus, CellCept, and prednisone. And you can see here probably the higher risk of or the higher level of immunosuppression is during the first 3 months post-transplant, where the patient also had received an induction therapy. And then probably we start after 3 months to start reducing the doses of immunosuppressant. And then probably after 12 months, it's because patients should take their drugs lifelong, but probably after the first year, again, probably is where the lower levels of immunosuppression we can find. So the influence of immunosuppression in vaccine responses will be, again, much higher during the first 3 months, because particularly in case we have received an lymphocyte depleting antibodies like ATG, that usually the effect lasts for some weeks. So this has an influence, and that's the reason why we do not recommend vaccination during the first 3 months post-transplant. But in an outbreak, we can do it, but probably the risk for not responding is a little bit higher. And then again, so MMF, this antimetabolite, has been identified as the drug that influences more the response to vaccine. And as I said, probably this drug will be, the doses will be higher during the first year, and then will be decreased after the first year post-transplant, which makes it, again, probably if you need to vaccinate someone, it's better to do it during the second year post-transplant and not during the first year post-transplant. But then there are some drugs that are used not so commonly that has a very big impact on vaccination, and maybe you need to be aware of that. One is belatacept, which is a co-stimulator blocker. And we have seen during COVID and COVID vaccination that people that are on belatacept had really almost no response to vaccine that was has been shown in COVID and influenza vaccine, but probably this is the true for most of vaccines. Again, it's a drug that is not used very usually. It's about 5-10%, depending on the transplant population. But you need to aware that the patient on belatacept, you should be very careful of how you vaccinate, and probably you need to look for vaccine responses. And the other drug is in case you have humoral rejection that could appear a month after transplantation. Then if you give anti-CD20, that is also very well known before, but also during COVID, that will have a very impact. So again, if you have it's not the majority of patients, but if you have a patient on belatacept or rituximab, then you need to be careful of how you are vaccinating your patients. So the question that we always been asked is whether we need to check for immune response. There are some good reasons for doing, because they inform you of the state of immunosuppression, they quantify the level of response, and maybe if you have some rules, they advise you whether you need additional booster doses, but it's except for a few infections like hepatitis B, there is a lack of correlation between antibody levels and clinical protection. Most tests do not evaluate cell-mediated immunity. They are not standardized assays, and usually it's time-consuming. Maybe one specifically for travel vaccines, one example where monitoring the response to vaccination and the antibody levels is with hepatitis A, because here you shows that hepatitis A is considered a very immunogenic vaccine with a very high, large number of responses, and usually after a second dose, you consider that you are almost immune to live, and almost 100% of patients. This is true in healthy volunteers, but in solid organ transplant recipients, that after the first dose, there's only a few percentage of patient that responds, that this increases almost to 100% after you giving the second dose. But if you test again 2 years later, you see that the life of the antibody response is much shorter than in controls. So actually, I think that each time that the patient travels or want to travel abroad, actually you need to repeat your serology for hepatitis A to control whether the patient is still immune or not. Only one word about yellow fever vaccine, and then I will finish my presentation. So I'm not an expert here. Probably there are people in the panel that are much more expert than me, but actually there's some kind of controversy whether a single dose gives lifelong immunity. So I think mostly in the United States recommend single dose. In Europe, maybe a little bit conservative and say that need for a booster after 10 years. So it's a live vaccine that's completely contraindicated post-transplant. So it's something that we're doing in our pre-transplant evaluation. We ask the patient whether he thinks that he will travel South America or Africa, or maybe it's some people that comes from these countries, from yellow fever areas. And then in that case, so we're doing all our best to vaccinate them before transplantation, either a primary vaccination if never received it, or a booster if it's more than 10 years after vaccination. We also say that in case of travel, we try to avoid any travel to region that where some outbreaks of yellow fever. And then, of course, in any case, we give, particularly if it had not been vaccinated, we can write a waiver letter that actually is acceptable for most government. So in conclusion, you need to plan well in advance the travel consultation, because maybe you need to check vaccine levels. You need to maybe see the patient one or twice to complete the vaccination schedule. You need to, I think, strongly advise to wait until 1 year post-transplant before doing a travel. And as I said, also diarrhea may have more consequences on solid organ transplant recipients, but prophylaxis is usually not recommended. It's done by treatment. Probably it's more feasible to do. And use malaria prophylaxis as in the general population. And I think it's something that it's well known, but live vaccines are contraindicated, but probably yellow vaccine lasts forever. So, and then I did not talk about it because of time constraints, but probably you can take advantage of your, they have the patient in front of you, not only to vaccinate against travel vaccines, but using also update for all other routine vaccines, influenza, COVID, zoster, for example, during your consultation. And thank you very much for your attention.
Excellent. Thank you very much, Oriol. That's a really clear presentation and raises a number of points. Now, we're going to have time for one question, which I'm going to ask verbally now, and we'll save up the others for the discussion. But before I ask that question, I'm going to just directly address the delegates. Now, some of you on the call know me, and you know I'm not shy of saying what I think. So at the moment, the number of questions is really abysmally low, I have to say. And looking at the names on the list, you can think of 10 questions each looking at the people on there. So please type away, because Cameron's going to lead the discussion and he's got his own questions, but he'd really like some from you. So any rude remarks can be addressed to me, but please send him your questions. Now, my question for you, Oriol, is this. I meet this when I'm advising on malaria prevention. That's a big part of my work. I'd like to know your red lines generally, not just malaria. For when you say somebody, well, you've had this or that transplant, you're a certain number of weeks out, and whatever you say, I'm going to strongly advise you not to go. So what are your red lines for saying to a traveler, really, you should maybe stay home and not go at this occasion?
Yeah, I think I would say that the majority of patients, and we're talking mostly kidney, liver transplant, heart, maybe lung, it's a little bit more complicated. Usually they feel great, and after 1 year, they're doing very, very great. And I think that in that case, I have no problem to say, yeah, you wanted to do this travel, or your life had been your transplant, so go ahead. So the only thing is we will discuss more time. We will try to catch up in vaccinations. We will try to reinforce all measures. But then if it's a patient with surgical complications, is a patient that has received rejection, is a patient that had already done a lot of opportunistic infection, fungal infection, I think that then you need to discuss and then saying, oops, maybe this is not a good idea. And maybe the travel that you wanted to do to Central Africa or something, maybe you can do it also in the Mediterranean area and being closer than a center which can deal with you or whatever. So I think it's a discussion between patient and health provider. I'm not usually don't put red lines. I think it's more a discussion because each patient is different and has their own goals, and they anyway, if you said no, you don't go with it, say I will go anyway wherever you told me. So I don't try to put red lines, but I feel much more concerned with a patient has all clinical manifestations that the patient is over immunosuppressed.
Great, that's really helpful, thank you. And I'm sure we'll come back to that sort of thing in the discussion, which Cameron's going to lead later on. So now, last but not least, we have Dr. Siriorn Watcharananan from Bangkok in Thailand. Dr. Watcharananan is an associate professor of medicine in the Faculty of Medicine at the prestigious Mahidol University and its associated Ramati Bodhi Hospital, and also an assistant medical director at the Med Park Hospital, also in Bangkok. So strong track record of relevant jobs for this, and in an area where there are a number of infection challenges. So Siriorn, we very much look forward to your presentation.
Thank you for kind introduction. So today I'm very happy to actually share my experience on cases of a returned traveler. And I'll be focusing on returned travelers with acute fever. Then I'll show some case-based approach, focusing on geography and incubation periods. There will be case presentation, focusing on clinical findings and also differential diagnosis. So this is a big world, and this is where I've come from. So I am going to present the case of the 49-year-old woman who is from Bangkok, Thailand. She presented with fever and a headache, which started 4 days after kidney transplant. From her history, she had SLE, systemic lupus erythematosus, and lupus nephritis, and she had kidney transplant years ago. She failed her kidney transplant a year back, but still on immunosuppression for her lupus nephritis. When she came in for transplant, she looks pretty healthy. Then 4 days, she had fever. Now, when you look at the social history, She said she joined a rice planting demonstration in a paddy field 3 weeks before the transplant, and her husband got flu A infection 2 weeks before her fever onset. This is the table showing fever, symptoms, signs, white cells, platelet, and also labs. You can see that there's many workup done because of her fever. She looked pretty sick. And from CBC, you can see the dropping of the platelet just a bit. Investigation, including CT brain, was done because of her bad headache. She had the blood tests, including adenovirus and CMV PCR done. She had urine blood tests for cultures, nasal swab PCR for flu, and film array for pneumonia for respiratory panel. They turned out to be negative all. But then 4 days after the infection, she seems to be sick still with a headache. Lumbar puncture was then done, and we show here that CSF was clear, and it's only about 4 white cells. Sugar, protein were all within normal limits. CSF film array for meningoencephalitis panel was also negative. This is the current problem list: acute fever in the patient who had second transplant that started 4 days after her second transplant. She had a history of travel to Pathum Thani, which is actually 1 hour driving from Bangkok, for joining rice planting in a paddy field. And her husband just had flu A infection. This is actually, I think, quite a real life practice. You have a fever in someone who had a history of traveling. Sometimes if you don't ask, they just don't tell you, right? So detailed history and physical examination is very helpful. And for this kind of case, you have to make sure that you don't have malaria as a possibility. Otherwise, you have to work up and treat accordingly. For fever, if you have no organ-specific symptoms, we can call it acute undifferentiated fever or systemic febrile illness. With this, there's several differential diagnoses that we have to think about. Most commonly, cosmopolitan causes, including UTI, abscess, cellulitis, for example. Common tropical, subtropical cause has to be looked for as well. Skin examination, scar, rash, something we always look for. And about 30% of travelers returning from the tropics, they have infection from something that's not related to tropical disease. Now, this is the slide showing the checklist that we have to obtain. As Michele has just mentioned, that we have to tease out the history and physical examination. And you know, ID specialists always spend like an hour asking for history for one patient. So not only the history of lifestyle, but also history of insect bite, animal exposure. Animal bites also very helpful. This is the slide showing the type of infection in travelers. And of course, diarrhea is the most common. Respiratory tract infection is the second most common. And among the fever cause, dengue, malaria were among the most frequent cause. This slide shows based on GeoSentinel database, you can see the difference in significant regional difference in the type of infection among the EU returned traveler. Fever is quite common in someone traveling from sub-Saharan Africa or Southeast Asia. Acute diarrhea is also common in someone who returned from South Central Asia. And again, malaria is one of the top 3 most frequent cause of febrile illness and the main cause of death. When you talked about life-threatening tropical infection in return travelers, we have to think about several things, but the top 3 include falciparum malaria, enteric fever, and leptospirosis. And you have to always remember when you ask patient about enteric fever, you have to kind of like asking about where they're from, because if they're from South Asia or India, the rate of multi-drug resistance is increasing. Now, getting back to the first case, if you think about differential diagnosis, you have to kind of like pull the clinical finding together and lab finding together. And then I think this is very helpful website This is CDC Yellow Book, and this is the chapter on the fever in return traveler. I find it very helpful because if you have the patient with fever, rash, arthralgia, and low blood counts, it's actually help guiding differential diagnosis. And actually, we can kind of like think about investigation after going through this list. And also geographic finding is very important. Again, from the CDC website, if you stay in Central America, while you stay in Southeast Asia, the list of tropical disease would be much different. Now, looking back in the rice farming system, if you see on the right-hand side in the picture, you see the rice farming ecosystem here. If you reside there for a while, you say that it's not just rice, water, and fish that you encounter with, but also wildlife, vectors, farm animals, and domestic animals. That's why there's increased risk of zoonotic spillover from rice farming, and you can see a bunch of organisms of concern on the left-hand side. Now, going to my case, if the patient is from Thailand, this is a recent study from last year showing the top 5 causes of infection in acute febrile illness. And here, when we say malaria, this day malaria in Thailand is only seen mostly in Thai-Burmese, Thai-Myanmar border or Thai-Laos border, while you see scrub and dengue here that you can see many of the cases in many parts of the country, including in northern part, southern part, northeastern part, for example. Back to the case here. So we actually did a bunch of workup, ending up that we had a positive test showing blood PCR for dengue, and it's dengue virus type 4. Now, dengue virus is something that we actually frequently encounter with in a country like us. And the viremic period is a good time when we catch the virus in the PCR testing. And this is an example of macular rash you see during the convalescent phase. This is one of my patients. In terms of comparing the clinical characteristic between this virus, dengue, chikungunya, and Zika, Zika seems to have a pretty mild presentation, while dengue can have the severe presentation, including hemorrhagic complication. Chikungunya is something that I actually feel bad for the patient because arthralgia and also severe joint pain actually last long, maybe a few months or even 6 months. This is another patient of mine, an example of immunocompetent host who had chikungunya infection. She had facial rash, joint tenderness, and arthritis, and also conjunctivitis. And you can see how suffer it is from this picture as well. This is an example of leptospirosis case in one of the Burmese patients who is working in, he worked in the local market in the middle of Bangkok, and he got bitten by a really big rat. And then a week later, he came in with fever and respiratory failure and jaundice. And you can see the dark urine here. This is from the article. You sometimes see conjunctival hemorrhage as well. So back to the case here. One has a question. Why bad headache? Why infection is so early after transplant? So incubation period is actually very important. For example, in dengue case here, usual incubation period is up to 8 days. So for our case, we tracked further. We did sample of the CSF for several testing, including arthropod-borne virus, rickettsia, and Q fever, and it turns out to be positive for dengue from the PCR as well. So we traced the recipient and donor further, and what we found is that there's a positive cell cultures and PCR from blood and also CSF, and we found a positive PCR in the recipient urine. And of note, kidney donors' blood show positive dengue IgM and IgG. This is actually one of the cases that we think it's a donor-derived infection. It is not from her rice farming, but it's from the donor-derived. So dengue virus infection has been a problem over the world, and it's actually been seen more common in transplant patients. You can see that presentation is pretty similar in immunocompetent and immunocompromised, but manifestation can be severe. And in one center, mortality rate is quite high as well. Now let's move on to the second case here. This is a 60-year-old man he's a Bengali man. He had a kidney transplant 8 years ago. Presented with 4 weeks history of sore throat and odonophagia. He had a week of intermittent chills and fever up to 40 degrees Celsius. There's epiglottic ulcer identified from laryngoscopy and which actually tests further and show herpes simplex virus infection. He had actually spiked high fever despite broad spectrum antibiotic. And from the history, he was born in Bangladesh and moved to the US 35 years ago. He traveled to Bangladesh 6 months before admission. And on admission, there's several tests that they've done, including CT scan of the chest because of the fever. It showed many ill-defined centric lobulus nodules in multiple lobar distribution. And 5 days after admission, there's ulcerated hyperpigmented nodules shown in the left cheek. They actually did further tests on that cheek, and it showed yeast forms and which further grew. Histoplasma capsulatum, BAL also grew the same organisms. So what I just show here is another case of uncommon case of patient who had kidney transplant presented with acute fever as well. So this is from the GO Sentinel analysis 20 years back, though the number of cases is much smaller than malaria and dengue. What they found is that histoplasma was the most frequently reported with the shortest median duration of travel. There's a study showing very interesting finding on travel-related fungal infection in immunocompromised. What they found is that the cause is majority of the cause is caused by dimorphic fungi and cryptococcus. What is very interesting is that infection can be acute or can be reactivated later or maybe years after exposure. But most importantly, when we think about something uncommon, we have to make sure that we exclude the common things, for example, malaria, dengue, and enteric fever. For these kind of cases, travel history is very important. So as any history of particular exposure. And again, when you have someone who has suspicious of lung involvement, chest X-ray may be misleading as the first initial test may be negative. And in case you think about disseminated infection, this requires multiple tissue biopsy from the affected site, including skin, maybe mucosal, blood, or bone marrow. In some study, it showed that this type of endemic fungi is only found in tropical and subtropical area. Here on the left side, histoplasma and cryptococcus can be seen in many countries, mostly in tropical and subtropical areas, as I just mentioned. Cocci, mainly in America, North and South. Tularomycosis in my area and also in China. This is another nice paper that I think are very useful. In patients who had solid organ transplant and suffer from endemic mycosis, major presentation was fever, and this disseminated disease was seen in about 70% as well. Mortality rate is up to 30%. Cytopenia are common for histo, cocci, and tularomycosis. This is my own experience of cases, most in advanced HIV. This is tularomycosis back almost 15 years ago. And of note, when you see tularomycosis like this with the skin lesions, you have to do blood cultures. And from blood cultures, when you do gram stain, it is actually not the type of one we expect to see, but it is going to be more of the septate or hyphae. This is cryptococcus, and this is histoplasma capsulatum. Either nodules or ulcers can also be seen as previous case. Well, I think you have to make sure that you don't misdiagnosis of leishmaniasis when you think it is histoplasmosis, because the lesion can be overlapping, and also the morphology of the tissue biopsy. Sometimes the kinetoplasm may be misidentified as histoplasma. Again, for cutaneous ulcers, you can see from several kinds of infection. And in my area, this is eschar from rickettsia, and most commonly in Thailand is going to be scrub typhus. This is going to be my last slide. What I show here is that there's actually some common radiographic appearance of pulmonary infiltrates that can be helpful in immunocompromise. However, I think it is still definite diagnosis is something we need to do. So we need to do tissue biopsy or microbiological workup to confirm the diagnosis. In summary, travel-related infection can occur in transplant patients after travel, and this population is more vulnerable to infection and respond poor to immunization. Consultation with travel medicine specialists prior to travel is prudent in order to provide the best protection for this population. And in a return traveler, careful review of prior epidemiological exposures, incubation period, and detailed physical examination are crucial, as these help guiding on differential diagnosis, further investigation, and the treatment. Thank you.
Hey, Siriorn, thanks for a great chat. Some of your direct experience there is really unique. So I value that a lot. Hey, we're closing in on time here. I'm going to take a sort of moderator liberty and say that for those who have to drop off, we're over the hour, feel free, but we're going to continue this discussion as much as I can. Siriorn, maybe I'll start a question to you, and this is going to then be open to panelists if you wish to jump in. You talked a little bit there about dengue, and I'm curious, would your recommendations for screening or in fact counseling to a patient be different if you knew it was someone who was coming from an endemic country like yourself, where they'd likely been exposed before, versus someone, for example, like mainland United States, where probably that person has not had dengue before? Thinking about the sort of likelihood of more severe cases coming on re-exposure, do you give your patients different recommendations? Do you screen them ahead of transplant?
Well, since my return to Thailand, I've been practicing as an ID, transplant ID, for almost 20 years. I would say that we probably miss a lot of dengue cases because we don't do donor and recipient screening before transplant. However, when you think about dengue and the country like us where resource is limited, when you see the impact of the infection, and we see that even if they have fever and they don't come to the hospital, the mortality rate of transplant patients without knowing they are sick from dengue is not increasing in my area. Or even when we look back in our study at our center in Ramatipadi Hospital, 20 years ago when we look, the mortality rate from dengue infection among those who was diagnosed and admitted was 0. So I think doing screening is useful. For example, the case of the dengue that was identified from Singapore when they do active surveillance or active screening, the rate of the screening positivity is only less than 5%, or less, even about 3%. So I think if we are going to do screening, we're probably going to do it during the endemic, during the outbreak, or during the rainy seasons. I think that may be more reasonable too in our area. Yeah, but in any other part of the world where resource is not limited, I think doing screening is not bad, because you can pick up a lot of missing case, and perhaps you can defer the transplant from that kind of patients, or maybe defer the organ. Thank you.
No, that makes great sense. Michele, I'm gonna pivot to you if you don't mind, and both riff off the screening questions. You're becoming an area that's known for dengue, sadly. Do you give different advice for patients who you know have been exposed before? And then my actual question for you is a little different. We had some comments in the chat about Candida auris and whether you would entertain the idea. Are we at the point of having to screen candidates for transplant who are coming from C. auris endemic areas? Is there a value there?
So great questions. First, for dengue, we don't do any specific screening. There have been isolated outbreaks locally, but in Key West, in Miami, but not sustained. A huge percentage of our population was born in and may have lived for a long time in dengue endemic areas. But we rarely see severe dengue. We rarely see hospitalizations, and we probably miss plenty, but we don't. It hasn't been a tremendous problem. I think the biggest risk for Candida auris is being admitted to a hospital, honestly. And we screen at our hospital patients who are coming in from facilities, mostly long-term care facilities, where we know there's significant amount of Candida auris, just so we can isolate them, be very careful in hospital. But I think, things may change. But for now, we're trying to protect the global hospital population from Candida auris. And thankfully, we haven't seen outbreaks in our dialysis centers, for example, where we'd have a lot of transplant referrals. So we have only been screening selectively. On some units, we screen universally for epidemiology within the hospital, but not pre-transplant specifically. We had a lot of problems actually during COVID in some of our units with screen positive for Candida auris, people who were mostly colonized, not ill. But I think that we've not chosen to screen pre-transplant. I'd be interested if any other centers are.
Yeah, we do not, but I don't know if others on the call do.
Well, we don't screen for dengue and we don't screen for Candida auris, but in our opinion, considering the epidemiological situation, we should. We had like this huge outbreak in Brazil in last summer. It was like awful, and we had some cases of donor-derived dengue. But it's important to mention that the viremia is very short, about 1 or 2 weeks, and that the virus can still be identified in the urine. And then this is a problem for screening. And about Candida auris, we know in literature that there are some cases of transmission, and we had an outbreak here in my city recently, and we didn't have any donation from that hospital for some months.
Yeah, so that sort of speaks to the dilemma that I think we have, which is if we know we have a donor who has Candida auris, particularly in their terminal illness, is that something that makes you more reluctant to donate with that organ, say, particularly for a kidney?
Yeah, yeah. We don't know exactly the impact of that.
Oriol, I'm curious, you spoke a little bit in some of the questions, especially about sort of modified travel advice after episodes of rejection. I'm wondering if I can push you a little bit on that. You know, some of our rejection therapies these days include B-cell depleting and antibody depleting therapies that really directly affect not only future vaccine use, but prior vaccination if you're giving rituximab. Do you revaccinate those people? Are they the folk who you might sort of recommend against travel? Like, help me understand how you'd handle someone who would have had recent rituximab post-transplant or any antibody-mediated rejection therapy for that matter.
Yeah, it's probably a population which is a higher risk for infectious complications. So that I would say that I will try to avoid that because also he needs to be controlled about the organ function and all of this. I think it's someone that needs to be a little bit more surveilled, so that going just after therapy of this, going to travel, it can be a little bit more complicated. That's the reason that I would say that I not advise to go for a big travel, maybe for a small travel, but not going abroad. There is really common sense. I think we don't have a rule that it's first month it's 80% risk, and then 2 months it's 20% risk. I think it's something common sense, and probably 3 months it's reasonable to think that maybe if the rejection has been treated and appropriate responses, then probably after 3 months he can start having a net state of immunosuppression that it's going a little bit how it was before. And then I would say for eculizumab and an ATG, probably after a few weeks, probably the effect it's going down, but we know that for rituximab that it lasts much longer. So probably if I want to vaccinate, depending on the dosage I have received, probably I will wait until 6 months for start testing antibody levels and then revaccinating. Of course, we have some kind of outbreak, or for example, during COVID, we can try to vaccinate a little bit before. In patients not transplant recipients, but that have received anti-CD20 for multiple sclerosis or rheumatological disease, even the antibody levels are not very good. We know that cell-mediated immunity is quite good even after vaccination after rituximab. So if there is any emergency to vaccinate someone, I will try to do it. But of course, it's very difficult to evaluate what would be the level of response. So again, it's mostly common sense, but I would say during the first 3 months, you better not to travel, and then you can start planning after that. And then if we need to vaccinate, probably we'll wait for 6 months to have a reasonable hope of having a vaccine response.
I appreciate the answer. I'm going to stick with you here for a couple of questions that had also come up. We're talking about the idea of sort of strategic double dosing vaccines. I know obviously in some countries we have the options of high dose flu vaccines, for example, but do you ever take a double dose strategy, or is there a way you think through those options?
Yeah, for influenza, we keep the 1 year vaccine, but as you said, so we try to give it high dose vaccination because there are several studies that show that the antibody levels are much higher with the high dose, which probably covers the fact that some people recommend a booster dose after 1 month. Probably, I think it's a much better strategy to give a high dose vaccination influenza. And then what we try, so in Switzerland, for example, it's only reimbursed for more than 65 years old. And then actually the transplant recipient, it's younger. We say that maybe you need to pay it yourself, but usually it's like $40, something like that. So the people usually accept if they understand that probably they will be much better protected with the high dose. So I would recommend, we're only doing 1 dose, but we try to push to have the high dose vaccine rather than the standard dose vaccine.
Yeah, that's the same with us. I mean, maybe the only exception I can think of is if I know I've got someone in the Northern Hemisphere season who I vaccinated.
Yeah.
Then in 6 months going to the Southern Hemisphere, I'll probably try and top them up.
Yeah, that's good point.
So one of the questions that I really would love to ask everyone's opinion, I thought there was a great comment here from Lara online, who sort of said, maybe, we're talking here about travel protection, travel medicine, but how do you, within your programs, get your patients to recognize that they still need to come for guidance? Have you had, like when a kidney transplant for us is 3, 4, 5 years out, we don't hear when they're traveling until when they get sick. Have you had successful strategies to make sure they give you warning, make sure you've had a chance to counsel them? That's a question open to anyone at this point.
Maybe I can start. So in our hospital is a small one, so we have a very small transplant program, and that we can a little bit control all the transplant recipients. And actually we're embedded so we're transplant infectious disease that are part of the team. I think most of you in the United States. So that actually is very easy to cross some nephrologist and cardiologist and then say, okay, hey, I have a patient that told me that wants to travel. Why don't you have a look? And then everything it's okay. So I think it's most this close contact than a very structured way of doing advice, infectious disease advice for solid organ transplant recipient. Can imagine in a larger transplant center, it's a little bit more difficult to do that. But yeah, I think that we're a little bit present everywhere in the transplant center so that it's easier to ask us and then to reach us for asking about travel advice.
One interesting issue that I would like to comment is the transmission of virus related to live vaccination through donation. Like it recently happened with the yellow fever vaccine, that we had like a devastated outcome through the donation of tissues and blood and whatsoever from a recently vaccinated donor, because it's something that we don't check.
Yeah, I don't think any of us in the United States, I'm not sure in Switzerland either, Oriol or Thailand, Siriorn.
That it's really bad luck, right? That that the donor was vaccinated, but imagine that was vaccinated in the few weeks before donation, right?
Yeah,
Because
that happened.
So it's really have no chance at all that, yeah. So because here in probably in your country you vaccinate much more often than here in Switzerland, which is only for travel vaccine for endemic region. So the probability of being viremic during donation because of vaccination, it's really, really. I don't think that it will never happen in Switzerland, but it's extremely interesting. Yeah.
Yeah, it's very rare. It happened in the United States. This episode was investigated. He received the yellow fever vaccine and didn't communicate. So, and then he donated the blood and infected the organ donor. And well, it can happen. It's rare, but it's something that we don't check usually.
I'm going to ask one more question, and I think we're going to push up towards our closing. Emmanuel actually in the chat has written a good comment. How feasible is broad-based universal donor screening testing, given the varying screening protocols that exist across different geographic jurisdictions and varying granularity of donor travel that you actually get from a history? Maybe I'll tee off with that one, and then I'd love to hear what other people think. I mean, in the United States, we have at least guidance that every organ procurement agency has to do a certain number of minimum tests, but it is not currently broad-based screening. And I can't imagine that within a time window of donation that you would necessarily know. But it's curious to think about whether or not finding some of that information out after the donation has occurred would still be helpful. Does anyone do this? I presume this is sort of more on a broad molecular-based screening.
Well, we do some universal screening at our center that other centers probably don't do, just because of our population. I alluded to Chagas, strongyloides. There's a couple problems with, for instance, screening everyone for West Nile. If you have false positive tests in those early days, you're going to lose some organs. And if you screen for enough things, you're going to lose a lot of organs, which may lead people to die on the transplant waiting list. So I think there's a plus there, a balance has to be reached. In addition, we found we had a fair amount of false negative strongyloides IgG in people with end-stage organ disease. Yeah. And we have a lot of strongyloides locally. So we elected to just prophylax everyone, because a couple devastating hyperinfection strongyloides cases, every other year was enough to make ivermectin worthwhile. So I think that each center has, because of geography, because of demographics, will have to have some set of screening, and that we all, for instance, can turn on our West Nile screening and turn it off in the face of positive local blood donation screening, for example. But I would be opposed to doing something universal, because I think we may lose some really good organs with false positive tests.
Yeah, Michele, it's Peter here. I strongly endorse your comments about strongyloides. We have a population in London where we've got a number of people from strongyloides endemic areas. It's not endemic to UK, but quite a bit of imported stuff. And the threshold for diagnosis of an illness due to strongyloides post-transplant is not that good. So from that point of view, we encourage, if you can test and get positive, treat. If you're really worried, you think there's a significant risk, then a single dose of ivermectin is well worth doing.
Wanessa,
So we also, yeah, it depends on the center because not all centers screen for strongyloides. Some centers choose to do universal prophylaxis with ivermectin because the test price, and also as you mentioned, maybe we don't know exactly the sensitivity of the test. But in my center, we do strongyloides screening, and also we treat accordingly. So that's how it is. In terms of the rickettsiosis or chikungunya and dengue virus, we don't have the universal screening. We've been monitor an outcome post-transplant, and we think we are open for the chance if we see that the infection gives such a big impact on our population. And so far, we don't see that much mortality from the arthropod-borne virus in Thailand. Yeah, thank you.
Wanessa, I might hand off to you for some closing remarks here. This has been great.
Unfortunately, we come to the conclusion of this webinar. We greatly appreciate your participation. A special thanks to our speakers for sharing their expertise and valuable insights, as well as all the attendees for their engagement and thought-provoking questions. We hope the discussion contributes to improve the awareness and management of travel-related infections among this vulnerable population and the potential donors. Thank you all. We look forward to seeing you in our future sessions.